So first of all, Happy New Year to all of you, and welcome to our guests. We are very pleased to have you here. Probably your first duty travel during the year. This room today, which means that you are all interested in the history of medicine and history of public health, which is very important development. So first of all, let me say that welcome to our guests once again officially, and we are extremely pleased to have this first seminar on the history of global health, which is actually a series of seminars in WHO. But in our regional office, this is the first one that takes place. But in WHO headquarters, such seminars have been organized since 2004. And they are about the history of medicine, they are about the history of public health, and the main purpose of such seminars is to further promote the understanding and the comprehensive response by the global health community on all the challenges that we have in the 21st century. And in headquarters, it is the cluster of Maripol Clinic that is organizing this seminar. And in our regional office, it is the Division of Information, Evidence, Innovations, and evidence base of our knowledge. Actually, the division that is headed by Claudia Stein, and they are responsible from today onwards to organize similar events for our staff. The issue is that Claudia is sick today, and therefore she is not here, and she apologizes, and she asked Arun Nanda to take over her responsibilities as of today, but only for today. The first seminar that was organized in headquarters was attended by Dr. Halfdan Mahler. And actually he was the keynote speaker, as I understand. And ever since, he is very interested in this topic. And he attends as many seminars in Geneva as he can. And it would be wonderful once also to attract Halfdan Mahler to come and attend our seminars, because we have not seen him officially in this office for a long, long time. Ever since he retired, we keep meeting him in Geneva during the World Health Assembly, and he's still in very good shape, but it's not very often that he travels these days. And we can also think of who would be the key speakers in our region who were closely linked to our regional office in the past. Like the previous regional director could be one of the speakers. Unfortunately, we only have one regional director emeritus in our region, who was here with us not very long ago, but he could be one of those. But there are many other people who are interested and who could really contribute to these topics. In Geneva, until now, there have been 60 seminars, if I understand correctly, and that is a big number. And the organization in the headquarters was always led by Professor Sanjoy Bhattacharya. I don't know if I pronounce your name correctly, but you are very, very, very much welcome. From the York University, and you are the main collaborator from early on, and a very enthusiastic partner in this development. And originally through the Wellcome Trust. But then a center was set up for the history of medicine at UCL London, and more recently, since you moved and established the Center for Global Health Histories at the University of York, you have been working there. And we are very pleased to have you with us today. And we also understand that you are accompanied today by your colleague, Dr. Alex Metcalf, and who is the outreach historian for the Center for Global Health Histories. And I would like to acknowledge that the support of the Wellcome Trust has been very important and very significant since the beginning to allow these seminars to take place. And they have always been promoting the fusion between historical evidence and the current approaches, and also the link between the academicians, the academic world, and also the policy-making world, and this is a big advantage and benefit. Also, the materials of the previous 60 seminars are very well documented on the WHO website, and they are accessible to everybody. So you can go into the website, there is a link where you can find all these materials. And we try to do the same also in Euro through a webinar in which all the colleagues from WHO who are not based in Copenhagen but in our GDOs and country offices, and also the colleagues from the member states can join. But we also try to record the events on our website so that historically we can always find whatever we want to find. What is very interesting in this seminar today is that this is the first one that takes place in a regional office. Until now, all the 60 were in Geneva. And due to a significant contribution from the Wellcome Trust, it has been possible to extend this seminar to the regional offices. This is the first one that we have in the European region, but this is the first one that we have in any of the regional offices, which will then be followed by the Southeast Asian region, and then I'm sure that also by the others. And today, our first seminar is about antimicrobial resistance. It's a topic that is very close to our heart, and the WHO Euro will be represented by Danilo, Wong, who gives the current overview. But we are also very fortunate to welcome Professor Gradmann from the Oslo University, who is sitting next to me, who will cover the historical perspective. And the AMR has a very rich history, we all know. And we also know that the risk of resistance to the antibiotics has been predicted and observed soon after the discovery of penicillin. And the WHO has been part of the history for a long time, attempting to raise awareness and engage all stakeholders for decades. Unfortunately, the perception is that despite of all the efforts that we have made in WHO and also in the other organizations like the EU and also in the member states, little progress has been made, which leads us to believe that examining the history of these attempts will provide us important directions for our future work, and we hope that this historical review will also help us to be more successful in the future. So with these words in mind, I hand it over to my colleagues, and you have the floor.
Thank you. Very quickly, I'm incredibly grateful to the Regional Director, Zsuzsanna Jakab, for, I know she's busy, that you've made time to be here. Lots of WHO Euro colleagues have given a lot of their time. We miss Claudia because she's been a tremendous force. Natasha's time has been on tap, so thank you. Arun has been very supportive. Danilo has been very supportive, and as has been our external speaker who readily agreed to join us, so thank you very much. But I'd also like to thank Ms Zsuzsanna from the Wellcome Trust, who's come over. I know he's incredibly busy as well, so thank you, Niels, and for all your support. And I hope you're happy with what's happening now in the regional offices. Apart from, he's also been attending seminars at headquarters. So I'm very pleased that you're here. I'd also like to thank colleagues at headquarters because they brought us together. So Dr. Asama Ba, Marie-Paul Keeney, Najib Al-Sharbadi, and Human Momin have been tremendous sources of support. And I hope Human promised to be on the webinar. So hi, Human. So thank you all for coming. I mean, to have such a wonderful party-like atmosphere on the first seminar is marvelous. A couple of colleagues there got the tone just right with your sandwiches. That's what these seminars are all about. Lunchtime webinars, coffee, sandwiches, fruit, very important for health. So thank you. Thank you all for coming. So, floor is yours.
Maybe I could get my presentation on this so that I can actually see it and work on it. Well, I'm glad to be, thank for the invitation to come here and to talk about my work. And I do think when I talk about the history of antibiotic resistance here, the paper I'm going to present you could be presented in no better place, because it's going to be a presentation where the activities of the World Health Organization in the 1960s and 70s will play a very, very important role. In some ways, for those of you, there's a bit of feedback here. For those of you who are not historians, it will maybe be bewildering to see something that's of still high current concern, namely antibiotic resistance, through the eyes of a historian. Well, I hope that will provoke interesting questions and discussions afterwards. And if there's anything that's totally unclear, or you can just ask into the presentation if you wish to do so. When I talk about the history of antibiotics resistance, I would first like to take you back into those days when the phenomenon was first observed. Of course, there was resistance before. Those of you who are medical experts will know that it's part of the natural history of this planet. But it only came to be observed as a clinical phenomenon. I don't know what's going on here. I have a lot of feedback. And I wonder if that's a good thing with the stream. Okay. So resistance had been around in natural history, but it only came to be observed the moment there was antibiotic chemotherapy taken in use. So the point in time when the phenomenon was first observed was about 1942-43, when the Allied military, medical, sanitary corps used sulfur drugs in masses, for example, against sexually transmitted infections. And that's when resistance first was observed. Still, for the first couple of years, it remained a phenomenon that was a very, very limited importance and would be considered something that's bewildering, something that went wrong in the treatment of individual patients. People would not have the idea that we have today, that we're dealing with something that's of a Could it be that there's a little microphone behind me? No? Okay.
Maybe a mobile phone somewhere.
So when it was first observed in a clinical setting, it was a bewildering phenomenon. It was therapy of individual patients that had gone wrong. And my simple hypothesis that I would like you to follow me through my paper is that it was mostly shaped by the way it was diagnosed. So people didn't have a fixed concept of what resistance would be. They were trying to handle patients, they were trying to handle hospitals where more and more of that phenomenon was visible, and by doing so, they were shaping concepts. And I would like to follow those concepts. Well, this is not working well.
No.
No.
Usually you have to point at the femur. Okay, thank you. So let's have a look at essential things that happened in the 1950s when you just have to keep in mind gradually there will be more and more cases of resistance occurring, and on the left-hand side you see an overview that has been taken from a recent publication where you can see, and this is on the example of the infamous Staphylococcus, that there's a gradual growth, and that Staphylococcus was not just resistant to methicillin as it is today, but there was already resistance of Staphylococcus to penicillin in the 1950s. What changes in the 1950s as compared to the war situation? I can still see my manuscript, so I'm fine.
Is it okay?
I don't think it's a good idea in relation to the camera. What we get in the 1950s is mass application of antibiotics, mostly also because they're moving from being injected drugs to being drugs that you can actually take as a pill. What we get in the 1950s and what in many ways shapes the phenomenon of resistance is the first 1950s superbug, what I call it. We get a penicillin-resistant Staphylococcus aureus And this particular bug has an interesting effect. It's for the first time that people realize that resistance is not a local phenomenon. They're identifying that strain. They were up to identifying strains before, and they realized they found the same thing in Southampton and in Sydney. So they're realizing this is not just getting difficult in local hospitals. This is something that's happening around the planet. So resistance is in the perception of those who do medical microbiology developing into something that seems to have epidemic character and not just therapy has gone wrong in individual patients. What then happens is that resistance that had been studied by other people before gets viewed upon as a medical phenomenon. I have to stare a few words on that. Who has been studying resistance before? It was two types of people. One of them was experimental geneticists. They were developing models of how you can study heredity in the laboratory, and they used resistance as a tool. Second people who did so was experimental pharmacology. They would use it as a kind of ex negativo model to understand the interaction of parasite and drug. So it looked like resistance was unknown, but it had been confined to laboratories in genetics and pharmacology. And now it was popping up in the clinics. And what changes here is the question of perception. Resistance from something that you can control and that you work with changes into something that arises uncontrolled and changes all the time. And we can see this in a little semantic change that's occurring in the early 1950s, when our modern word resistance actually becomes what we think it is today. When people in the 1930s would write about resistance, they would talk about primary and secondary resistance. So what's primary and what's secondary here? Primary resistance would be a stable trait of an organism. That could be a bug, who is not susceptible to this or that drug, but it could also be us, who are not susceptible to the common cold because we wear warm socks, for example. And then people become aware that there's something like secondary resistance which can be induced in a parasite. And they would actually call that secondary resistance in the interway use. And it's in the early 1950s that the secondary resistance disappears, and resistance is now viewed upon something that's evolving all the time. It's no longer a stable trait of a microbe. The result of that is, to make a long story short, is the creation of a new subdiscipline of medicine, which is clinical microbiology. So expertise is now no longer only to be found in genetics and experimental pharmacology. There is now a field within medicine that specializes in studying these phenomena. So how would they diagnose? Let's have a look at my second slide and how people diagnose. There we are. Resistance in the 1950s. I think for those of you who are experts, little of that will actually be new. There's two things you have to do, and in both cases, the necessary technology has been developed by the geneticists and the pharmacologists, but now it became adapted to medicine. First, you have to determine specificity. Which strain are we dealing with? And you could use two technologies for that. You could do it by using phages, or you could actually do a serological test. Very quickly, clinical microbiology decides to do it with phages, and mostly that's because it's quicker. And time plays a role. Time didn't really play a role for the geneticists, but now it plays a role, and people go for the phages. And that's when our epidemic of the resistant staphylococcus that created much of the infrastructure in the 1950s gets a new name. It gets named after the phage employed in diagnosing that particular strain. There's now Staph 8081, and if you talk to a retired microbiologist, they will all remember that one. It was a real eye-opener. Secondly, you have to determine sensitivity. So this very quality that has become so flexible and movable. And for that, you have in principle two tests, and one of them was very laborious but precise, and the other one was exactly the opposite, I would say. So you could do a tube dilution test where you had where you would place an inoculum that would contain the suspectively resistant bug on a culture medium that was mixed with antibiotics. And you could do that in different dilutions, and you could very nicely determine the minimal inhibitory concentration. That's actually something that became also created in those days. But it's very laborious, and it could only be done by specialized laboratories. many other people would do it the other way around. So they would mix, they would grow the speculative resistant bug on a Petri dish, and they would then add a little paper disc that contains the antibiotic in question, and then they would then just watch out for inhibition or growth. Actually, in those days, people would not do what you can see on the picture on the lower left. So the size of the inhibition zone would not be considered to be a relevant piece of information because the paper disc was very poorly defined. It could be any type of paper disc. It was actually equipment that could be produced in the hospital kitchen. It was there was lots of different paper discs used in those days. So, it was a simple on and off test of very low precision, and the quotes on the left-hand side illustrate the situation in the 1950s, where people actually thought that the phenomenon of antibiotic resistance was getting more and more attention, but the tools to study it were by no means standardized. People were just continuing with the local practices they had before, even though we're now facing a phenomenon that was acquiring global character, so to say. So that's how things were in the 1950s. Let's have a look at how WHO got involved into all this. Well, WHO had an antibiotics committee, which had been founded right after the creation of WHO in the late 1940s. But that had initially been a committee that had, in line with politics of WHO, been more interested in disseminating technology to produce antibiotics around the globe. Also, it was a sleepy committee. There was not a lot happening. They were meeting once or twice during the whole decade, and I couldn't find much traces of activity here. What happened in the late 1950s is when WHO moved from this post-war reconstruction into trying to make recommendations for the development of health systems around the globe, is that the Antibiotics Committee becomes subordinated to something that's Health Laboratory Services. That is a unit within WHO which in those days had a public health agenda. So it is a much wider perspective on the phenomenon, and it tries to view laboratory work on antibiotics as part of a public health perspective of controlling the phenomenon. One person became very important here, Hans Eriksson, who is quoted on the upper left. He was head of the microbiological laboratory at Karolinska in Stockholm. And he made the claim that medical microbiology should become an independent discipline. It should be more than just a service unit in a hospital. It should actually be a new discipline of medicine. So the expert group for antibiotics becomes subordinated to the Health Laboratory Services division, and in 1961 it starts to study antibiotics, and it sets up what I describe on the right-hand side, an international collaborative study with the aim of creating what's missing, that is diagnostic standards, standard procedures and standard equipment, actually, both of that being envisioned. This was run by Hans Eriksson, whom I've introduced, and his colleague John Sherris, who was a clinical microbiologist in Seattle in the USA. And it was sponsored by WHO for a decade, and you will get to see some of the people it involved. They met frequently, they did quite a lot of work. What was the objectives of that study? It was providing reference. So they wanted to design reference methods for how to do the tube dilution and the disc diffusion test, so that everybody around the globe would have a reference test that they could refer to. That thing didn't exist. They explicitly wanted to guide clinicians. I do think that is connected to the aim of promoting medical microbiology to a science. So the idea was not that the clinicians should actually be very creative in using this. The idea was more that the microbiologist should develop some straightforward methodology that was comprehensive enough to be handled by a clinician. And finally, this should also enable WHO and others to have diagnostic standards that would make results of laboratories around the globe comparable. So you could actually do some epidemiology, because so far it was not clear whether what the laboratory in Southampton had observed was actually the same that the laboratory in Sydney had observed. But the moment you would standardize around diagnostic technology, you would then have a standard which would enable you to do epidemiology. How did they do it? Well, they had to start from scratch, and it's visible, I think, in the type of approach. They took test strains of suspectedly sort of the usual suspects resistant microbes, and they would distribute them among a fairly small group of elite laboratories. It was less than 20 laboratories involved here. They would all be elite medical microbiology laboratories. And they would be asked to run their standard procedure. And then you would compare what would be the result. You would meet, and since you were working on the same strains, you have this as a reference point from which you can then discuss how the methods would differ. Let's take a closer look at this international collaborative study. You see on the left-hand side a picture of that group meeting in 1968 in Sweden. On the left-hand side, the guy with the nerdy glasses, this is Hans Eriksson, conveniently placed under a map that shows Sweden as a regional superpower in early modern times, I think. And facing him, with the back to us, with the black hair, that's John Sherris. And the other ones are people from important institutions. So there's somebody from the Institut Pasteur and from all kinds of high-profile places. So based on doing that comparison, they designed standard tests, but they also envisioned a system on how diagnosis of antibiotic resistance could become much better on this planet. And the idea is that there will be a small group of publicly controlled elite laboratories, maybe pretty much the group that was actually collaborating on the study. And they would be up to handling the laborious dilution tests. And they would provide reference methods, regression scales, and all kinds of advice to everybody else. Standards here would be publicly owned. They would be defined by publicly controlled institutions, and WHO would serve as a platform where everybody would meet. Clinicians and industry in this system were thought of as users. They would have little influence on the standards. That's not quite what happened, but that's how the system was first envisioned, so to say. The committee was also up to making recommendations for a disk diffusion test, and we have to keep in mind that the disk diffusion test had developed since the 1950s. I've mentioned that in the 1950s it was a very simple on and off test where the size of inhibition zone would tell you nothing about the degree of resistance. In 1965, a method was published, and there were several moves in that direction to actually have a method where the size of the zone around the disk would give you some idea about the degree of resistance. And the so-called Kirby-Bauer method is an important step in that direction, and the ICS simply adopted that. Actually, Sherris had been one of the authors of the Kirby-Bauer original paper where the method was published. In some ways, this is how the ICS worked, but we also have to be aware that if we take a closer look, that it tried to transpose a system of monitoring and handling antibiotic resistance and antibiotic use that had been developed in Sweden, Norway, and Finland in the years before. So Eriksson, in his own laboratory in Karolinska, he practiced what I would call a deep standardization. So, for example, everybody doing antibiotics diagnostics in Scandinavia would be invited to regular training courses in Uppsala. Even the equipment used to diagnose would be produced. So they had standardized the paper discs, and they would be produced in his institute in Stockholm. And laboratories would be publicly owned. So we see a system that's rational, but that's also, in a sense, learning from the Scandinavian experience and trying to take it out into the rest of the globe. Denmark, by the way, wasn't really part of that system, so calling it Scandinavian is not quite correct, actually. However, that's one part of the story of how resistance changes during the 1950s and 60s. There is a second story, and this evolves in the United States. I've been talking about the paper discs, and you will by now have understood that the paper discs are very important because not so much because they give a very precise diagnosis, because they're simple to handle. They're very popular. They were very often, for example, bundled by producers with the drug. If you would get antibiotics, they would deliver a couple of paper discs with it for you to be able to calibrate your antibiotics use in your hospital, which will also nicely kind of make sure that you would not switch to somebody else's antibiotics, because when you bundle the diagnostic equipment and the drug, you can only calibrate one drug. You cannot really easily switch to another one. However, the quality of those discs was, as I mentioned, was appalling. They had been homemade or they had been produced by all kinds of companies. And I'm quoting their Canadian researcher, Arnold Branch, who did a survey of the quality of discs, and you would even discover discs that did not contain antibiotics at all. So the amount of antibiotics in it, for example, was very widely. This situation in the early 1960s, FDA tries to move in, and they try to impose the pre-market certification of the discs. They try to say, okay, we have to make sure that discs have a reasonable quality in order to have some reliable diagnostics. This right of FDA is checked by one of the producers to say, hello, discs are not drugs. You cannot standardize that. You have no mandate to do so. The whole thing goes to the Supreme Court. At the end of the day, FDA wins and creates a standard. Now that's a very different standard from what WHO and the Scandinavians have created. Scandinavians and WHO have been something that where the discs are an element in a large system where there's also procedures, training courses, dilution tests, and whatnot. FDA CDC creates what became known as the National Collaborative Committee on Laboratory Standards, and they impose a certification of the discs, and that's it. They stay with that single element in the process. And also they have a different committee, and that committee is not just public laboratories, it's industries and laboratories doing the work together. So the discs become an object through which industry and clinical medicine and experimental microbiology make a compromise on how to diagnose. It's by now easy to see that these two approaches were not really in line with each other. What is evolving here, and you can read through the quotes yourself, is a conflict between the CDC FDA approach that goes for certification of this and for incorporation of industries, and the WHO-sponsored approach of Erickson, who goes for a public health-inspired approach of handling antibiotic resistance. And Bellows, the head of the microbiological lab at CDC, makes his argument that it would simply be an infringement of property rights if we would force the producers to join the system that the Scandinavians have envisioned. But what then happens is that the Antibiotics Committee changes ownership. And in a large institution like WHO, that's a very significant event. It had so far been owned by this Health Laboratory Services Division, which had a public health agenda. And it became moved to biological standardization, that's a very traditional activity of WHO, standardizing biological substances like vaccines. It had started in the interwar years, actually, before WHO even existed. And it had traditionally been a committee that would standardize substances alone and would have no problem with having dealings with industries. Erickson, of course, is frustrated because he sees that his work is stopped here. CDC is working actively against those standards being adopted. However, there was also principal arguments put forward, and the person I've mentioned, Bellows, the head of the microbiological laboratory at CDC, he's making together with others a few criticisms of the project as it has evolved as ICS. First argument is that you can't really standardize biology. They're aiming for a level of standardization that is very laborious, because the bug will always escape your standards. They change all the time, so they say this is not feasible. We should be content with a little less standardization, actually. They also proposed, the argument was also they had proposed methods to handle for clinicians which were much too complicated. Clinicians were not up to handling that. Finally, there was an infliction of property rights, and my interpretation is that's how we can sum this up. It's a conflict between a technical standardization that focuses on one object, the paper disc, and a public health-inspired standardization of the entire diagnostic process. And if you wanted to see how this works, you could maybe go to Stockholm and have a look. The result is that the ICS actually gets dumped by WHO. And Ericsson's and Cherys's work, which is delivered as a report in 1970 to WHO headquarters, gets scrutinized by a group of experts that are hired from the other side. And WHO, as you can see on the next slide, in the quote on the right-hand side, denies ever having had the intention to create an international standard of antibiotics diagnosis. There is not, never has there been any question of WHO giving any kind of approval and so on. This is an all-out denial. And the British Medical Journal and everybody else was aware that this was a U-turn anyway. So a departure from the original intention was at Geneva. The most outspoken critics of Ericsson and his group and Cherys become advisors to WHO, and the results of ICS are not published in the technical report series of WHO, which was originally the plan. But I wonder if that's easy to read. It's called Acta Pathologica et Microbiologica Scandinavica. So they go back to Stockholm, and that's where they publish the whole thing. So is this the end of the story of Ericsson's aspirations? It is not. There is a surprising turn with which I would like to take you to the end of my paper. And what you see on the left-hand side is a letter that Hans Ericsson, by that time not only a university professor, but also the owner of a company that produces diagnostic equipment, which is called Biodisk, has been. And Ericsson had become a producer of those disks. I've told you that before. But his colleagues at Karolinska were not very fond of something being run from outside of their walls that was beginning to look increasingly commercial. So they forced him to outsource it. And for him, that was a good idea, because he now became the owner of a company called Biodisks. And he would offer, in many ways, what the ICS had been after, now as a commercial service to companies. And in this letter, he's trying to make contact with the Bayer company in Germany. He said, look, we're offering you reliable diagnostic equipment, and you can use this to increase the prestige of your antibiotics. Sensitivity testing here now becomes something that's part and parcel of marketing. If Bayer wants to be a producer of antibiotics that aspires to a high scientific standard, you can make that point by referring to a diagnostic standard that's controlled by a third party, even though it's no longer public. It's now controlled by a private enterprise. That's about as far as I want to take it with my story. And I would like to sum this up in a few words. One question is, why do I stop at about 1975? For once, I could say I stopped because ICS is and the whole project is safely dead and buried, and Biodisk is becoming a producer, but also diagnostic work is changing. So far, I've been talking about work that was done by hand. It was laboratory work that would be done individually. You would work on the individual Petri discs. From the late 1970s on, it starts to be automated. There is machines doing the work, and standardization is very tricky, but it's a different type. The other questions that I would like to ask is, has there been change? I think there has been a lot of change. If we envision my presentation, then we see that there has been quite a bit of progress in terms of the quality of diagnosis from the early 1950s, where you would have some paper disc of undefined content that you would place on a Petri dish, and it maybe give you a reading or maybe not, to 1971, where you have the published study of the ICS that would actually contain all those standards, even though they were not compulsory. You could relate to those if you wished so. I've mentioned the importance of the discs as a marketing argument. In many ways, ICS didn't really work out because there was no international standard created. At the same time, it became a standard nonetheless. If people would do epidemiology of resistance around the globe, they would very often refer to those methods in the upcoming years. And for example, that's maybe where I close, the people who run WHONET today were actually trained in Sheriff's laboratory. And that's how the stories connect. Thanks for listening.
Do we want to take questions now, or are we going to move on to the next presentation?
Before you move on, I'd like to say bye-bye because I have to leave. But before I do so, I'd like to thank you very warmly for this very interesting insight and presentation and history. And I'm sure that there will be a lot of discussion and a lot of questions to you as soon as we have also listened to Danilo. And thank you again to all our guests who have been here today. And we wish you a very nice afternoon. Thank you.
Okay, thank you very much. And I know this is a difficult time slot right after lunch. I'm privileged to see you here dozing off, so I hope I'll keep you interested. Thank you very much, Christoph, for a very interesting historical insight as to how we are where we are today. And keeps me wondering where we would have been if the ICS had been successful and had not been dead and buried. But so we're still faced with the challenge of antimicrobial resistance. And what I would like to present to you is not only the history of the efforts, but the renewed efforts at WHO. So my name is Danilo for Wong. I was appointed Senior Advisor on Antimicrobial Resistance a little over a year ago. And I work together with Dr. Nienke van der Zand, who's right across from me, together with the AMR team, but we're working together with lots of other people in the organization as well, because it is a very challenging and complex issue. Okay, we haven't really talked too much about the antibiotic era, but that's just what we're calling it since the discovery of penicillin by Alexander Fleming. And since its discovery, there's been many different antibiotics and antimicrobials have been developed, and we literally saved millions and millions of lives. I mean, I think we're doing things now which we could not have imagined before. But one of the major things that we're doing is we're not only treating infection, but we're also preventing infection, which allows us to do very complicated surgery by the use of antibiotics and antimicrobials. It's also said that together with vaccination, antibiotics have been responsible for increasing our life expectancy with about 20 years. I think that's quite incredible. And the other thing that was also discovered through its use, that it's also been used to increase productivity in livestock. Now, and as Christoph also said before, with antibiotics come antibiotic resistance, or actually it's always been there. It's a natural phenomenon. It's not something that we created, but it's something that we actually are, increasing. It's accelerated by the use, just sheer use, but also overuse, underuse, and misuse of antibiotics. By misusing antibiotics and creating antibiotic resistance, some treatments will fail, and some infections cannot be treated anymore, which means that some people actually die from their infection, or their treatment is prolonged, so it's costing more money, it's keeping people longer away from their work, so it's affecting their livelihoods, and it's basically undermining all the progress that we've made since the discovery of penicillin. The other scary trend is that there's very few new antibiotics in the pipeline. This is something that you will hear again and again. And with that I mean, I think it's illustrated quite nicely in this graph. The colored lines that go up here are various types of resistance that are on the rise from the 1980s to today. For example, this is MRSA, multicillin-resistant Staphylococcus aureus. And the blue line going down are the number of companies that are researching antibiotics and the number of antibiotics that are being developed. So and these are two reversing trends. And of course, it doesn't take a rocket scientist to extrapolate these graphs and see that we might end up in a situation where we don't have any drugs anymore that are effective. Some call it going back to the pre-antibiotic era, some call it going towards a post-antibiotic era. But the effect is the same. If we're not able to treat people anymore, you can, from a simple infection, you can die once again. It's also not a new phenomenon to WHO. It's always been very interested in the work, and I was happy to see that Christoph found earlier involvement than I could find. But this is just a list of years of meetings that were held at headquarters on the topic, starting in 1971 up until today, actually. So it's been on the WHO's attention for a long time. It's also, WHO's been trying to promote the idea of having to do something about antimicrobial resistance through these years, through its main governing body, which is the World Health Assembly, which is held once a year, as you know, in May, representing all member states. I think the earliest resolution is from 1980s, 84, 86, and has been repeatedly brought to the attention of the countries of the Ministry of Health. A huge effort was made in the turn of the century, in 2000. In 2001, there was a global strategy published on the containment of antimicrobial resistance, and Dr. Danilo was instrumental in that, is here. But what we've seen, and this is also a general perception, that even though this great piece of work was published, the progress itself in implementing is being questioned, at least. It's not been widely implemented. Now the question could be why. Why wasn't this a success? Could it be that there was no global momentum at the time, the turn of the century? There was just no interest. We're also very unlucky about launching the strategy on a day where another big tragic event happened, which took all the media coverage. But of course, that is not enough to explain why nothing happened, or why limited progress has been seen, at least since. The other thing is, was it a lack of guidance? I don't think so. It's a very comprehensive report, 105 pages, so it's not overly long. You can read it over the weekend if you're not busy. It had 67 clear recommendations of interventions. So through studying this, we know who to educate, we know who to encourage, we know what to ensure, we know how to monitor, we know what to monitor, we know who to empower, and we know what to establish. So lots and lots of good interventions in one book. The only thing that was sort of missing is how. I think that's a big explanation why it's only partly implemented. Could it have something to do with its complexity? I think it does. And this is just to scare you. It's a schematic representation of the epidemiology of antimicrobial resistance. Not to go into any details, but it has an animal component, has an environmental component, a human component, and they're all interlinked. And so the epidemiology is challenging. The other thing that's challenging is that all these parts are dealt with by different parts of government, different bodies, different agencies, that are all doing their own thing. So it is a very, very complex issue. Could it be that there was a lack of awareness, potentially, at the time? A lack of commitment, for sure. Lack of accountability. Were there any lack of resources, innovation, lack of laboratory capacity? I think that was made obvious here as well. Lack of implementation, definitely. Was lack of infrastructure, sure. Lack of coordination, sense of urgency. Examples, were there any good examples out there at the time? Maybe not. Was there sufficient surveillance? Was it seen as a priority? Were there enough strategies? Was there enough collaboration within countries, between sectors of government? Did we have success stories at the time? Was there an interest at all? Was there enough expertise and experience? Were there incentives? Tailored approaches? Was there just a lack of leadership? I don't think there was a lack of leadership, because I think, as I've seen, WHO has been engaged and involved for the last 40 years at least. But I think that the type of leadership was maybe not correct. It was a passive leadership. We did what we usually do. We got the experts together. We figured out what needed to be done, and we published it in guidelines and offered it to the people who were supposed to implement it. But I think what was needed was more of an active leadership. It's to create a few good examples, create successes, and build on that. And I think that was the main thought behind the World Health Day in 2011. The World Health Day is always celebrated on the 7th of April, the birthday of the organization. 2 years ago, the topic was Combat Drug Resistance, and the slogan was No action today, no cure tomorrow. I think it was a very well chosen slogan because it does highlight the need for action, no more talk, action, and it highlighted this sense of urgency. If we don't do anything now, there's no cure tomorrow. So the World Health Day was well celebrated around the world. It was also well prepared by colleagues at headquarters and in the regions with a toolkit for our usual audiences, the health ministers, stakeholders, and partners. It had a policy package background paper, which in a way was a simplification of the 2001 report. So it was addressing the main target groups, but in a more concise way. It had policy briefs, fact sheets. Events were organized around the world, which was really impressive, and a press kit to make sure that all these efforts were also known to the public, with news releases, statements, and videos. What it also called for was a more realistic concept of AMR. I think Christoph just showed it that it was seen as a medical issue. But from analyzing the complexity of it, we've now come to the realization that it's not only affecting the health sector, there's other sectors involved, agriculture for sure, communities. It's affecting not only the people that get sick, but the people that they should be taken care of or their jobs, the private sector and governments. So what we need to realize now that it's not only a health issue, but it's a social and an economic issue. And that realization has to be there in order to progress. So what can be WHO's role in all this? The one thing that we've been doing very well, but I think we should still continue to do, is increase global awareness. It's not only, we tend to preach to the converted, to the people that are aware of the problem and the people that are already supporting us, but there's a great audience out there that just doesn't take it serious enough yet. We have this convening power. We can bring all the key stakeholders together, talk to them, engage them, connect them, link them, to make sure that our approaches are more better linked and better planned between the sectors and between countries. And also, if we're doing so, we can be better at using the existing resources, identify initiatives that have similar objectives, similar visions, and try to pair them up and make sure that we create synergies and basically make better use of our resources. Provide guidance, yes. I mean, it's still out there. There's many reports, not only just WHO material, but from other institutions, foundations, networks that is very useful. But the main difference would be to facilitate action. And facilitate does imply an active role, not just to say what needs to be done, but also be part of how it's being done. Planning approaches that are acceptable for all players, that we can do as a neutral party. Facilitate implementation, maybe not globally, maybe not all at once, but create some champion countries along the way that other countries can look up to and be motivated to mimic. And of course, ensure equity, which is I guess a WHO core value. So what's been done so far since the World Health Day? I think things have really accelerated again towards implementation. Now there is a centralized group, a unit at HQ, small but dedicated, since December 2011. They were very quick to organize a global meeting internally at first to get all the regional offices on board and create a global task force, which is not only looking at what is already out there, but trying to align and share information about what has worked in our region and what is working in the countries that we're working with. High-level awareness raising is something that they can facilitate because they're at the core of WHO. And last year at the World Health Assembly, together with the Swedish and Ghana governments, they organized a side event on the topic, which was very well visited and was very interesting to be a part of. Then just before Christmas, we had a global consultation with experts from all around the world, basically. It's a bit of a dark picture, but we were there. The meeting was focused on surveillance. Surveillance is one of the basic things that need to be done, because really we need to know, where are we? What's the status? What are the issues? Are there any increasing trends? And can we measure the effect of our interventions? So this group was mapping the existing surveillance networks, what is already out there, what can we build on, what should be the objectives for a global AMR surveillance? Because of course, on one hand, there's country differences, regional differences, but there has to be some sort of global overview which is generic around the globe. And what would be the roadmap towards developing such a system? The other idea is to start working on a coordinated AMR action plan. It's another strategy, but an action plan, or roadmap, if you will, to be better at communicating the good stories, the lessons learned, and the advice. To make a global report on the AMR status. We briefly discussed, do we need another resolution? Luckily, we soon came to the conclusion that we did not need another resolution. There's plenty out there. What we need to show is where we are and where we could be going. And this global report should facilitate that. And then finally, a stakeholder meeting later this year to get those important players on board that are still skeptical, but we need for successful implementation. So bringing it back home to Europe, what do we know? What's our situation? We are doing surveillance in Europe, which is good. And this is one of those traffic light maps, they call, which are produced by the ERSNet, the European Antimicrobial Resistance Surveillance Network, which is hosted at the ECDC. And here you can see that countries have different colors depending on their proportion of resistance to, in this case, Staphylococcus pneumoniae. And of course, if you do this from year to year, you will see trends going through Europe. You will see east-west, north-south movements. You will see maybe the effect of interventions in certain countries. So this is Staphylococcus pneumoniae. This is another example of resistance, vancomycin resistance to Enterococcus faecium, methicillin resistance to Staphylococcus aureus, and Klebsiella pneumoniae. Resistance to third-generation cephalosporins, fluoroquinolones, and immunoglycosides. Now, you see, as I went from one map to the other, you see the countries change depending on their resistance patterns. But of course, there are a large part of the regions that do not change color, and that white color means no data reported. It's not the same that nothing's being done. It's just that we don't know about it. It's not being shared internationally, and this is important because pathogens, resistant or not, they do not respect geographical borders or even biological borders. So we need to know what's going on. We have the same for antimicrobial consumption. These maps are also there, but we see the same gray areas. But they're part of our region and they're part of the world, so we need to know. So we want to address this challenge, building on the momentum that was created by the World Health Day last year, or now 2 years ago. Recognizing that the issue is still, well, I wouldn't say ignored, but it's not being addressed properly, and definitely not internationally in a large part of the region. There's no systematic surveillance that we know of, and as I said before, international travel and trade is really accelerating the spread of pathogens, and sometimes with resistance as well. And this just shows you that there's a need for international data sharing and for standardization, as we mentioned before, so we can start comparing and start finding out where these things are coming from and how we can stop them from spreading. So there was an action plan adopted at the regional committee, which is sort of the regional health assembly in 2011, so the same year as the Antibiotic Awareness Day. It was fully endorsed, luckily, so these are our marching orders. It was developed through consulting the best brains in the region, And of course, we took stock of what was already out there. We didn't start from scratch. It's coherent with global plans because, of course, the spread of infections not only within Europe but also outside Europe, of course. And this really called for close collaboration with many, many partners. And it had 7 strategic objectives. And we'll briefly go through them, in the interest of time. So the first one is to strengthen intersectoral coordination. As I tried to show you with this complex map, it really is a complex issue. There's lots of different players, lots of things that need to be done, but these need to be coordinated. And one way of coordinating this is to have some sort of a mechanism, it could be a committee, it could be a board that regularly meet with from different sectors and try to coordinate all these activities. And they would be the ones asked to draft a national plan. The second one, as I mentioned before, is to strengthen surveillance of antibiotic resistance. Again, first of all, we need to know where we are, what's the status, what are the movements, how can we break these trends that we're seeing. So first of all, strengthening national surveillance, but also making sure that this national data gets shared at the international level by creating regional databases. One such initiative is something that we started earlier this year. We call it CSER, which stands for Central Asian and Eastern European Surveillance of Antimicrobial Resistance, which basically is an extension of the IRSNet that I showed you before for the countries that are not linked up to IRSNet. So it's a network of national surveillance networks for those countries in the region that are not linked up to IRSNet. It was signed here on the 30th of October, and on the left-hand side you see the DG of the Dutch Public Health Institute. On the right-hand side, the president of the European Society for Clinical Microbiology and Infectious Diseases. They both come with very strong expertise, and they're helping us setting up this network. And of course, because we want to have comparable data, we have to do this in close collaboration with the other existing network at ECDC, using the same methodology. That will then allow us to compare for the entire region, which is what we're interested in. The third strategic objective is about promoting rational use or stewardship in antibiotics, and also strengthening surveillance of antimicrobial consumption through setting up national mechanisms for the consumption side as well. And there's a similar initiative also run here at Euro, together with the University of Antwerp, who was responsible for a European network called ESAC, European Surveillance of Antimicrobial Consumption, before it went to ECDC, and now they have also offered their services to WHO to recreate that success for the other part of the region. The fourth strategic objective is about a very basic thing that we must never forget, that prevention is better than cure. So strengthening infection control and surveillance in healthcare settings is very important. The fifth strategic objective is huge in itself. It's taking care of the animal side. So the veterinary and food sectors, again, surveillance, integrated surveillance, measuring both resistance and linking it up to antimicrobial consumption. And in the same year as the World Health Day, this booklet was produced called Tackling Antibiotic Resistance from a Food Safety Perspective in Europe. You might as well have taken the in Europe out, because it's a globally applicable, very useful booklet, which you can easily get either from the web or here. And there's some discs I can see, easy to take home with you. Another big initiative in that same realm is organized throughout headquarters, organized from headquarters, called the Critically Important Antimicrobials for Human Medicine, which is basically trying to define which medicines are critically to human use, which you then not should be using in agriculture. Which is not to say that we should keep the good antibiotics for the humans and the substandard for animals, just to make sure that there's no cross, or as little cross reaction as possible, cross resistance, so that at least the stream of antimicrobial resistance coming from animals and food is limited. So the sixth strategic objective is all about, on the one hand, replenishing the pipeline, making sure that there's innovation and research going on in new drugs, new classes of drugs, but also maybe revisiting some of the old drugs that were abandoned before, or alternatives to antibiotics. And that is something that has to be done actively, not just in the industry, but also with other governments, research institutions, and academia can play a role there. And the other thing that's sort of, I'm not sure if it was foreseen in this strategic objective, but we were made aware by some of our partners that we work with that it's not enough just to make a new antibiotic. You also have to be sure on what are the rules, how are we going to distribute this. I mean, you don't want to make the same mistakes again and heavily promote a new drug and create the same problem over again. We have to be smarter about this. So that's something that also falls under the strategic objective. And finally, continued awareness, patient safety and partnership. Those of you may recognize this little hedgehog, which is the mascot of the European Antibiotic Awareness Day, which is also run out of ECDC. And this year, for the first time, we've allied with them and tried to make it a truly European day, so not just for the European member states, but for the EU member states, but for all member states in the region. And again, the broad partnership at the national regional levels are accentuated here. So some of the considerations for implementation before I end. We need a roadmap. We have all the knowledge of what to do, but we need to find out how to do it and what would be a logical sequence. So we need a time frame for the implementation, estimated resource needed, input, process, and output indicators, so that we know we're actually making progress. And a stepwise approach. I think some of the other initiatives may have failed because we've been too ambitious or not enough involved. So one of the things is that we have to work with some countries to see where they're at, do a country visit, and make a roadmap for the country and guide them and facilitate a plan towards success. So promoting the national coordinating mechanisms, promoting a national action plan, and making a national roadmap, and to basically also build up that surveillance capacity, which is so important. And for that, we need the structure of WHO. So all levels need to be represented. We need headquarters for the global picture. We need regional offices for the regional flavor, if you will, and of course country offices, which are important for the implementation. We also need to link up with and get the blessing of the governing bodies at these three levels, so World Health Assembly, regional committees, and member states. And most importantly, I would think a whole army, since we are combating antimicrobial resistance, of partners in different networks. We have a whole range of collaborating centers, which are very specialized institutes that can help us. Universities, non-governmental organizations, foundations, other agencies, and experts as well. Before rounding off, I would like to acknowledge, and also just to give you an idea of who the people are that are working with this, both at the European office and in headquarters, and also in country office and regional offices. And with that, I'd like to leave you with a quote that a coordinated global response is urgently needed. Nobody is exempt from the problem, nor from playing part in the solution. And this comes out of the strategy from 2001. And with that, I'd like to thank you for your attention.
Okay, we have about, we should have half an hour for questions, which is how Claudia planned it, and I would like to stick to that. I'd like to commend both speakers. My vague memory of these things is that Fleming, when he actually invented them, when he also predicted very clearly that there would be resistance. Now the question I have is, why has it taken us so many millions of years to arrive now at the understanding what he already predicted? And it's a good question that needs answering. The fact that surveillance was mentioned already in the WHO 1958-61 report, and there has not been, even in our region, which is the best in the world for surveillance, not one single initiative until ECDC and Zsuzsanna actually started it in 2006 and 2007 in Stockholm. So these are questions which I have. Also, I think we should give some credit to our member states. We are sitting in Denmark. Denmark was one of the countries in 1991, if I remember correctly, actually did an action plan or something, or declaration, I can't remember, you who are experts will know better, which actually, again, were ignored. So there are reasons to ask ourselves the question, and more importantly, not from the point of view of AMR as such, but the point of view for public health in general. For TB, this is a huge, big issue. So I think in order to learn from these things, we have to introspect and understand. And then you gave a hint. You gave a hint about leadership and passive leadership. And I do remember the letter that Zsuzsanna wrote to the DG in 2006 on this very issue. And I'm very pleased that we have now the World Health Day in 2011. But as WHO, we should start to look. You hinted at how many committees? I think you counted the number of times they met or something, if I remember correctly. You have described, I don't know how many, 11 WHO meetings without a single outcome other than more paper. So I'm very pleased with the progress that is now. But if we are going to use these seminars to do something important for all of us, then I think we have to start our question, what have we learned from this which could help us more generally? So with that provocative intervention, I took part. And by the way, very interestingly, the ECDC initiative has also led to a cross-Atlantic collaboration with America on this. So it's very interesting that now America is again following Europe. Thanks.
Yes, I can maybe comment a bit on the question. What is it that Fleming saw, and what is it that we see today? And Fleming, of course, made the prediction that resistance will be an issue, but that's because the phenomenon was already known. So he would observe what happened in his petri dish, which is inhibition of growth by an antibiotic. And the phenomenon of resistance had been described by the experimental pharmacologists decades before. So he would just predict this would happen. But there is a major step to be taken. And that's seeing it as a technical problem that you can get around by using another antibiotic. To our view today, that is actually something that is inherent in the use of antibiotics and that we have to control through the way we use antibiotics. I think Fleming and his generation, they thought that for a very long time people think that you can actually get around the problem of antibiotic resistance by using the right antibiotic in the right amount. They see it as a technical problem. The whole epidemiological dimension in it was added much later. I think that's maybe what differs most in relation to Fleming.
Sure. I was only starting from the history from the start. But as you raised in 1960s, I think what you are saying now was known.
It was known, but it was not accepted to be a guideline for how to handle antibiotics. People would, if you look, for example, at the marketing campaign for methicillin, methicillin was marketed as the ultimate answer to hospital infections and antibiotic resistance. So people thought of it as a technical solution to the problem. Mm-hmm. That it actually turned out to be the precise opposite of that is a different matter. But people thought that the solution would be around the corner. So there was an untempted faith in technology in those days. And as long as that prevailed, it was very, very difficult to have a different view on the problem of antibiotic resistance. And that only happened from the 1960s and 70s. And commenting on what you said, I've been talking about medicine, but I do think when it comes to the question whether it's awareness of that as a systemic problem actually come from, I do think that the agricultural side was more relevant. In the late 1960s, people went out actively against antibiotics use in animal husbandry. There's a classic paper by Bernard Dixon, which became very widely cited, Antibiotics on the Farm, which for the environmental discourse left the expert circles before the medical discourse. The medical experts would discuss it as experts, and then nothing much happens. While the agricultural experts fairly quickly actually managed to mobilize the public already in the 1970s.
Is there a list? if you want one.
Hi, I'm Joya Cordova. I'm a researcher at the University of Copenhagen. I think I can. Okay. And I work at the General Practice Unit, and I have actually two questions. Dr. Danilo mentioned there's a specific objective about the increasing surveillance and clinical guidelines specifically for in hospital settings. But why not a specific objective about increasing surveillance and implementing guidelines at primary care level when 80% of the antibiotics are prescribed at primary care level?
Okay, that's a very good question. And what I failed to say is that surveillance, we don't see surveillance as the answer to antimicrobial resistance attacking. It's actually the start of it. So what we really need to know is to find out, well, to make visual what the problems are, where they are, and then from that how to tackle it. And then we can use surveillance. Once we do intervention, we can use surveillance again to see whether our interventions have an effect. But you're absolutely right. The whole problem of over-the-counter sale or over-prescription is, of course, very, very important. And that's something that we have been addressing for a long time, but it's something that we really need to raise awareness within the community of prescribers, if you will, that what the sides and the negative effects are of that practice. And that really is a big challenge. But you're absolutely right.
Yes. Then can I have a second question? Okay. And my second question is, first, my opinion is that really the use of antibiotics has been really neglected at primary care level, and then most of the governments are asking doctors to, yes, the health systems are asking doctors to prescribe more prudently. But then when you are in the consultancy, you just there's a real huge uncertainty about if it's bacterial or viral, and you have the responsibility for the patient. So what do you think about bringing high technology to primary care to have that certainty that there's a bacterial or it's a virus, so you are using the antibiotics when it has to be used?
Yeah, again, a very good question, and that's exactly what's very important. But I wouldn't necessarily say it has to be high technology, but it has to be close to the patient. I agree with you. And prudent use is not necessarily reduced prescription, but it's smart prescription. Then you say, when is it bacterial, when is it viral? That's really important to know. And I'm looking at you, Caroline, maybe because we've discussed this quite recently about the need of distinguishing early on whether or not it makes sense to prescribe antibiotics. So I think that's definitely something worthwhile to look more into. Would you care to comment, Caroline?
I mean, I can just comment briefly. We were just discussing are there tests, point of care tests around that distinguish bacteria from viruses, and I thought we discovered one in Denmark, and we were going to look into that. And we know there's a company in Israel that has one, so we're just starting to explore that. So that's all I can say, but it sounds pretty useful to me. And I had a question or comment. Human nature is you only take action if you absolutely have to. So what is the impact? I mean, you've shown the surveillance is showing, okay, there's a big increase in antibiotic resistant strains. And I think that's the main focus of the surveillance, which strains increasing in which countries. But what's the impact? I mean, how many severely sick people are there or death due to this? Is that going to be part of the work?
Yes, I think so. What we just showed is based on seven pathogens that are either indicators for community-acquired or healthcare-associated infections. It's just the tip of the iceberg to show general trends. It's something that we can compare between countries, but of course, what you're saying is a country responsibility, and that's something that they need to do something with that information and react to that. And I think that just the fact of being part of a surveillance system makes you much more aware that this information that you're generating needs to lead to some public health action. Absolutely.
And maybe just one more comment, because our colleagues from the University of Copenhagen brought it up. Prescribing behavior by doctors, by GPs. And you mentioned raising awareness in the campaigns. But if I look at your advocacy materials, I think it's on the front page of our website, it says don't take antibiotics unless they're prescribed by your doctor. But the problem is you go to your doctor and he wants to give you something. So, you know, I felt that's giving it away a bit.
No.
Interesting. I think my first question was not only to know how many, what levels are. What she's saying is, what does it mean in real terms? How many deaths are you averted, etc. So I think that's a new development which she's mentioning, which is interesting to take on, because otherwise we're just following what ECDC has started some time ago.
Oh, absolutely. But what it means in terms of actual lost lives, disability, economics, I mean, those are very important questions that actually we need to find out more about, because that's, I guess, one of our main arguments towards policymakers. That's the kind of language that they understand. They don't relate to a number of deaths or a number of illnesses. They relate to what's the social and societal impact of that. And there is work going in those directions, but it's proven to be very, very complicated. Because of course, antimicrobial resistance is an additional complication to an infection. And how do you attribute a certain effect to the resistance or to the disease or co-diseases? You know, it can be done, but it's very timely and very costly. But luckily, there's some groups working on that, and that information is slowly coming out. Christoph.
It would actually be more a question to you, because you've mentioned the empty pipeline syndrome, and I've been looking into that, and it's actually even a bit worse than you've been showing it to us, because it was in the 1970s that industries lost faith in antibiotics, and you can see that they, for example, that they scale down their screening programs and do things like that. And the question is, as a citizen, I would be interested to learn how do you want to get industry to move into that field again?
That's a very good question. It's a very difficult one, and people have asked me before, and my answer usually is that probably WHO may not be the best equipped to have that discussion with the private sector, because for many good reasons we are in different camps. So we do realize that we need to work together. They are a stakeholder, an important stakeholder. But in terms of communicating that message, it's very difficult, and we do need other partners, NGOs, to help us with that argument. No, it's just it's a difficult argument that we have. We ask them to create or to develop something that we don't want them to use. This is bad for business.
In actual fact, in ECDC, at the time that we started the European Antibiotic Day, at the same time with DG Research, and that's where the figures of the lack of any of the alpha drugs, or I don't know, it was alpha drug or beta drug, which was actually only one in the pipeline. At that time, of course, through DG Research, the intention was precisely to do what you're saying, to try and encourage research into new antibiotics, to try and encourage the industry. To some extent, I agree with Danilo that we are in a difficult position as WHO, but not in an impossible position by any manner of means.
And actually, there's two, I guess, main initiatives that we work with to address exactly this question. One would be REACT, and the other one would be Antibiotic Action. They're very much interested in not only promoting maybe new incentives or new models, new business models that would make it interesting for industry not only to develop it, but also on how to distribute it after a new drug is developed. So there's a lot of attention on it, but it's a very complex area with conflicting interests, and again, a WHO which is somewhat constrained in direct dialogue in this sense. But through our partners, we can sit around the table and make sure that there is at least some drive towards this.
I mean, maybe a comment on these issues. Industry needs a return on investment, and in fact, you have two options. Either you are asked to develop a drug and you are asked to keep it in reserve as a second line or third line, and then you don't have a return on investment, or you release it and then resistance developed, and then nobody takes the drug anymore because it's resistant, then you don't have a return on investment. So there is no incentive from the industry to invest unless we go for a huge partnership, private-public, which I understand is ongoing actually with the EU, for instance, so we should build that kind of partnership. But the industry alone, which is business-driven, has no, I mean, I understand the disincentive, because to develop it, either you keep it in reserve, or resistance developed. So it takes probably 10 years to get a return on investment in the drugs. Yeah, sorry, I'm Guenel Rotier, I'm the director of communicable disease and a supervisor of drug resistance.
I also understand we have a few questions from the webinar, which we would address.
Someone is asking if you could maybe say a little bit more on when the alternatives to antibiotics began to be developed and what progress we have attempted.
Okay, so the question was about the alternatives to antibiotics when they were developed and a little bit more about it. Well, this again is a very new area, I think. And some of the alternatives that have been used is, or mentioned, is phage therapy, probiotics. But the thing is, it's all very preliminary at this stage. What I do know is that you're starting to see conferences now which are addressing alternatives to antibiotics. So not just about developing a new antibiotic. So it is something that is on the rise and very promising. But I think it's very early to say now where that is going. But at least there are groups, especially in academia, that are interested and working on the subject of finding alternatives. Any other questions? That was it? Okay. Question from the floor.
Here in the second row. Thank you both speakers for the excellent presentations. I liked very much the first presentation because it showed actually that already then, yeah, scientists were coming together and discussing issues, and which I feel that, yeah, we are still doing, and also in the last years, at least that I was working, yeah, people have been coming together to discuss these issues. And well, certainly I think there have been more meetings than just mentioned here, especially also for TB, also discussing problems with yeah, treatment of TB, second line, third line drugs. One of the problems with TB, yeah, some of the second line drugs is also that we actually do not have laboratory capacity to yeah, to see if the drug is resistant or not. Actually, and so also we need a lot of attention there. And with regard to the, actually also Arun's remark about the surveillance, why we start so late, and I think we started longer than the 2006 when ECDC became active. For instance, for TB, already 15 years we've been doing active surveillance of yeah, TB and also drug resistance in TB. And this initiative was already collaborated also with WHO and before EuroTB, which was supported by DG Sanko. And I'm not sure about the other, I think Nienke is also willing to respond on that.
Yes, the EARSnet is now at ECDC. I'm Nienke van Sander. That actually started in 1998, 1999, at the National Institute of Public Health in the Netherlands, and it went to ECDC in 2010, and it has been prosperous ever since. So it's yeah, it's good. And HUNET, when that started. It's not really, you cannot really call it a surveillance system. It's more a tool for surveillance. I'm not sure when that really started. Maybe Gunel, no?
Yeah, when it started in 2000, 1999.
If you're going back in history, then let me tell you that all these networks actually started from this office in 1991, and they started under a project called ENS Care, which was funded by the Commission. And these networks have stayed alive in some of our member states and actually now moved, as you say, to ECDC. So it's not a question of the fact that networks were there. The point I was making, and I think that's the lesson we have to ask ourselves, we can collect a lot of data, but if we don't do anything with it, the data is worthless. The effort is worthless. If we have a lot of committees, produce a lot of guidelines, but we don't, and we produce strategies, but there is no action, that's a waste. And our member states are getting irritated as well. Why do we need one more strategy at headquarters, another strategy in the regions? That's the question they're asking. And I think we should be in a position to respond. That's why Zsuzsanna is saying we're not going to have another regional strategy, we will have an action plan. And the reason for the action plan and the specificity for each region is obvious. Each region is different. So I'm in favor of action plans which have specific actions for WHO, actions for the member states, then we move forward. But data without some use of it is irrelevant. The fact that we started is good. It was mentioned already in your 1961 or whatever it was committee that surveillance was terribly important. But that's the way it is. Please.
I have a few comments, and I think this whole issue of surveillance is very, very important. I would say that even though HUNET formally started in the 2000s, actually it started in the idea to have something like that started in the closing days of the ICS when Thomas O'Brien was, because epidemiological data were piling up, and he was trying to use computers, which was not easy in those days, and he started plotting lots of data and putting them into graphs, in some sense HUNET goes back to the early 1970s, even though it really only became what it is today a lot later. TB surveillance has always been a lot better than surveillance in relation to other diseases because tuberculosis has such a rich history institutionally. So it's a disease that has created its own institutional reality in hospitals and institutions. So there was always a lot more surveillance in relation to TB than in relation to other diseases. Generally spoken, I do think that if you look at the question, how much documentation is there that we can have a look at for past events, then public attention does the job. You can see that in the early 1990s, when everybody was talking about the end of antibiotics, that's when good data are created. So I'm heading a research project on the history of antibiotic resistance in the recent history in Scandinavia, and you can actually see that the whole data is becoming more dense in the 1990s, and the date 1980, as we mentioned, is absolutely correct. That leads to even better data. So there's no way you can do this on a technical level alone unless you don't have public attention, you don't get the money to create the databases.
There's another question coming from the web, which states national action plans will need to be different for developed and developing countries, dedicated to the extent by the burden of disease, social economic conditions, ministerial commitment, resources, etc. So how will WHO ensure sustainable outcomes in the context of this diversity? And that's exactly what the action plan is about. It is about tailoring the actions to the country needs. And one of the ideas of what the country needs is to visit the country to make sure that they have a committee of representatives from the various key stakeholders who will then together develop a national plan which is geared towards the need of the country and building on what is there. And of course, if nothing is there or if little is there, the more needs to be built. But the approach in itself, the stepwise approach, is rather generic.
Absolutely right, Danilo. And in fact, going back to Caroline's question about what's on our web, the direction of that is for some of our countries, of course, where you can get antibiotics across the counter. The point is that it is strange, and we should make that clear, because it is strange to someone who will not understand that at all, because Europe is so diverse, and that's why the question is very relevant also to Europe. I mean, when I was in Uzbekistan, I was shocked to get antibiotics across the board. Why is TB resistance a huge problem in Uzbekistan? Partly because people are taking drugs all the time for things which are not even connected. They get TB and they're already resistant.
We might even think of situations outside of Europe where there is counterfeit drugs and no surveillance at all and whatnot. So, also true in that.
Which is also why I think that the WHO response should not only be active, but it should be done at all levels. There are global issues because there is travel and trade between continents, between regions. There's the regional diversity and there's country diversity. And I think just the structure of our organization is we are equipped to take on that leadership role and to make sure that we do something which is useful for the country, the region, and the globe. Other questions?
Danilo, if you could say a couple of words about the in this concept of global health, what should we do in terms of AMR and international health regulations? So if this was, yeah, I wanted to ask this. So if this issue was discussed during the meeting in December in headquarters, and what we are telling member states?
So I can say that the issue was discussed. And I think the interesting thing was that, of course, the IHR is very much geared towards emergencies, like here and now actions. And I think there was consensus around the room that although AMR is an emergency, it's sort of a slowly occurring emergencies. And there will be AMR events, or there will be events which have an AMR component, which are directly under IHR. But I think what was discussed was that just the ability for diagnostic ability, epidemiology, and all these things, they have to be core capacities under the IHR. And I know that in the IHR there is a small hint towards AMR being a potential AMR issue, IHR issue, but it's still geared towards international events here and now, whereas AMR is sort of slowly but surely developing emergency that needs to be addressed in a different way, but using the core capacities of the IHR. But to
certainly, IHR is not a surrogate to a control program. But of course, if an event involves antibiotic resistant strain that rapidly spread and need to be stopped, then the HR framework can be used. I have a question on to the historian, in a way, because we're always looking for success stories, and you mentioned Scandinavian countries. I'm already keen to have actually some success stories to show. So I was just wondering, do you know anything that could be shown? That I heard that in Sweden, I think there have been at some point one antibiotic removed from the market, and then we show sensitivity increasing again. I mean, that kind of issues that could be used and be, I mean, create confidence for countries that there is an intervention that may work, because we can always speak about the problem, but it's true that the issue is to find or to propose an intervention that works and encourage countries to do something.
I feel a bit uncomfortable with the question about actual successes, because I'm not a microbiologist. I work as a historian, but I do think that if we look at and also historians don't make prognoses, so there's no recipe that we can draw from history. But what we can see is we can identify factors that contributed to success stories of the past, so to say, and then the surprising and puzzling observation is that it's often unintended successes. So to give a very shortcut example is that in the country where I live, in Norway, I think reimbursement rules have been very important. So people basically have to pay themselves for their antibiotics, and they had to do so all the time. But the reason for that was not really that people were aware of the growth of antibiotic resistance. They were short of money, and they would have a health system that would rely on generic medicine and on keeping antibiotic consumption low. And our impression in the research group is that this was more done with the intention of saving money than actually controlling antibiotic resistance. It turned out to be the right thing after the event. I do think one can also, that's really something that the expert would need to answer to. I do think that Finland has rather impressively controlled community MRSA, I think. I do think they have some successes in relation to that. So it's not like it's an unstoppable rise. It's dependent on how you handle it, and I think that's maybe the sort of general lesson that you can take from history, that resistance is not in the drug, it's in the way we handle it.
Yeah, if I may, one more time, and I forgot to introduce myself before. I'm Kristin Kramer from the MER-TB program here in Europe. Also for TB, we have had some nice success stories. Actually, for instance, some of the Baltic states, Latvia, they had a really very big problem with MDR-TB, and they have been successful in really reverting the MDR-TB epidemic. And yeah, also we have a WHO collaborative center there who's supporting, and also training other people and countries to show them their strategy towards that. And also, I would like to say just a remark from another perspective, from the bacteria perspective, and also historical perspective. Because before I joined WHO, I spent many years working in molecular epidemiology of TB, also surveillance of molecular epidemiology of TB in Europe. And we really see that in Europe, it's actually a few TB strains that's causing the MDR-TB epidemic. And also there are examples for Pseudomonas, for instance, that some of the strains are more successful than others in surviving all these antibiotics that we are throwing at them. For Pseudomonas, there really have been evidence that there are hypermutator strains. So in that sense, that's also something like we could not have predicted, like even 20 years ago, we didn't know about that. And it's something, it seems that the bacteria are also smarter and smarter, and we're selecting the smarter ones. And this is something also, yeah, we couldn't have predicted in that time. Thank you.
Thank you very much, Kristin, for that remark. Are there any other questions or comments? Maybe also from the web? No? So mindful of the time, I think we've sort of outlasted.
I'd like to thank our guests. I didn't know we had a guest from Copenhagen University. Thank you very much for coming. I'd like to thank once again the Wellcome Trust for not only their support, which has allowed this seminar to take place, but also for being here. I hope you found it interesting. And of course, I thank very much our guests, Sanjoy, for all your, how can I put it, drive, enthusiasm, perseverance. We changed the topic of this seminar a few times, as you know, fixing the date. So really, thank you very, very much, and also to our colleague Alex. And of course, thank you for our two speakers. Thank you to Professor Gradmann for coming from Oslo. And thank you very much, Danilo, for managing the whole thing and arranging it. And thanks to our unit of DIR and Claudia Stein. I know Claudia put in a hell of a lot of effort for this seminar. And the fact that she's managed to get Sanjoy to do it more than once, I hope will be a pleasure for all of you. And I hope that I hope we gain from these. I mean, I gained a bit, and I hope that we can gain from the experience of such things. And the fact that in headquarters they've done it 60 times, there must be something which is good for us also. Thank you very much for coming. Thank you for your lunch.
Yes, please. I just want to very quickly add that this is not a project that in any way tries to suggest that historians are here to provide lessons that can be a policy use. All we want to do through these seminars is to have these discussions, and I think today's discussions were a wonderful example of people in an organization, people from outside of this organization coming together, talking about difficult topics. And believe me, it is as education for us historians to be hearing all of you talk amongst yourselves. So we hope, as this scheme expands, it will be a general educational experience where we learn from each other and speak openly, knowing that many of the views expressed are personal views, of course, the organizational views, of course, but we'd like to know the personal view as well. If we're, one of the things we at York would like to do is to put you in touch with academics you don't know already across the world. And the Wellcome Trust is a fantastic organization linked up globally with a lot of academic research groups. And one of the questions I had was, what about public-private partnerships in new antibiotic research? And the Wellcome Trust, I think, has really set the standard in South Asia by starting the Hilleman laboratories, where they've brought in the Indian government. They have put in significant sums of money into vaccine research, but also brought in the private sector, thereby cushioning any loss of profit that the industries are worried about. And I just wonder whether at some point Danilo and Neil can have a chat, and perhaps Danilo can go and meet people at the Wellcome Trust, where similar arrangements don't have to be guaranteed, but just talked about. So the whole idea is to get people talking. So thank you very much, all of you, for joining us today.